So we'll be discussing about the treatment for the heart failure. So what are our therapeutic goals when it comes about treating heart failure? And for that, let's make our basic foundations here. You need to know that the way we treat acute heart failure is going to be slightly different from the way we treat the chronic heart failure, right? So the management of the heart failure is going to be different, right? When it comes to acute and chronic. Now, when we say acute, we're talking about the acute decompensated heart failure, which means that they're actually showing clinical symptoms. They are symptomatic patients, right? Like for example, in just a quick review, when your ventricle fails, when your heart fails to what? To propel the blood to meet the metabolic demands of tissue, right? Of course, you have something called low cardiac output, right? Low cardiac output. Either we're talking about systolic heart failure or we're talking about diastolic heart failure, right? There's going to be cardiac output is going to decrease. Now, as you know that your blood pressure is equal to what? Your systolic times your diastolic, right? Diastolic, this is systolic. Your systolic pressure is directly proportional to cardiac output. Your diastolic pressure is directly proportional to your TPR. This is from your basic physiology. Now, coming back here, when there's acute heart failure there, the left ventricular and diastolic pressure is higher, so as your left atrial pressure is going to go up, everything's going to back it up. There will be increase in what? Pulmonary venous pressure, right? These are pulmonary events. So you have a excessive fluid is backing up, right? This is called backward failure, resulting to a lot of the fluid is going to leak out from this what? From the pulmonary capillaries, which means that there's a transient fluid is leaking out from there, this pulmonary capillaries, because there's a venous congestion is there, right? That result into what? Edema in your lungs, or we can simply say pulmonary edema, right? And that pulmonary edema is the one that's going to contribute something called dyspnea, which is a shortness of breath, and in medical term we call them dyspnea, unpleasant awareness of your breathing, right? That's what you get orthopnea, which means that when you're standing, right? If you're standing and suddenly you lie flat, right? You have a difficulty in breathing, right? Or you have a worsening of your dyspnea, and that is called orthopnea. And you also have at night, sometimes you have to, while sleeping, because venous return increases because of the redistributions of our blood, right? And that can induce something called PND, paroxysmal nocturnal dyspnea. This is from the pathology, right? But I'm just going over just for quick recaps. Now, these ones are what? These are symptomatic, right? And this is usually caused by what? Acute decompensated heart failure. So when there is acute decompensated heart failure, or when there's symptomatic heart failure, the way we manage is different from the chronic heart failure. Because in the chronic heart failure, usually the patients are from the acute, they have become to chronic, meaning that they are in a like normal volume state, okay? They are euvolemic state, okay? Normally. That's the one difference you got to remember. Plus, usually they don't have a pulmonary edema like we just talked about PND or dyspnea, right? They have. And if there's a right ventricle is also involved, they usually have like a reduced jugular venous pressure or the distensions of jugular venous pressure. Plus, they don't really have something called peripheral edema or pitting edema. So they don't have symptoms of a congestive heart failure. That's what I'm talking about. Let's just say when you talk about the chronic what? Chronic hypertension. Chronic heart failure, not hypertension. Now, when we treat, let's just say, when we do heart failure, we're talking about heart failure treatments, right? We're talking about the heart failure treatments. So again, the way we do acute versus chronic. Now, we're just going to write down acute heart failure treatment is going to be a little different from the chronic heart failure treatment, right? Now, when we talk about acute heart failure, that means that they are what? Symptomatic, right? So they have we'll write down here something called, they have a pulmonary edema, right? Which means that they're going to have what? Okay, dyspnea, right? Dyspnea. They have a orthopnea, all this kind of. They might have those, PND, paroxysmal nocturnal dyspnea. These are classical symptoms of that. They have a heart failure cells like that, right? They have difficulty breathing. They have dry cough. They have those rails which are high pitch sound, right? Which are soft high pitch sound. They happen because by opening what? Those smaller airways during inspirations. So these are classical symptoms. Plus, they might show right ventricular heart problems like increase in what? Jugular venous pressure. They could have that, right? So they'll have, and obviously we'll say that they'll have a edema, specifically like pitting edema, or like the peripheral edema, right? That a dependable edema. They'll have the classical signs and symptoms of this one happens. But you're talking about, let's just say, chronic heart failure. Usually, they are, let's just say, normal volumic state, normal, right? Euvolemic. And then they also have, like, for example, usually they don't have this pulmonary edema sort of symptoms. So no pulmonary edema sort of symptoms, right? Like dyspnea, orthopnea. Their jugular venous pressure is not distended. So that this, I'm making an X with this, right? So this is not there, this is not there, right? Plus, like no, let's just say edema, usually it's not present there, right? So this is a chronic heart failure. Now, so when we manage, let's just say, for example, the acute heart failure, let's just write down the list of the drugs and we'll talk about, how do they work. Now, here, let's write down the drugs that's actually, we commonly use, let's just say, acute, decompensated heart failure. Like, for example, when they come to your clinic, right? For example, they come to your emergency hospital. And how are as the emergency physicians, how are you going to manage it, right? That's something. One thing you should always do is this, look, you got to look for the airway assessment, right? Airway assessment is very, very important. Right? This is something you have to do. Second thing you got to remember is, like, for example, when you're looking for airway assessment, make sure that, they're getting, whether there is a, they're getting oxygen, or they're getting proper supply of oxygens or not, or they're becoming ventilated or not, right? If not, you need to make sure that, you give them what? Oxygen, right? Or ventilations if it's indicated. This is what you have to do, like airway and oxygen supplies. This is very, very important, right? Third, right, you have to put them in like the vital signs, you have to do that. Fourth, like you got to do like something called cardiac monitoring, right? This is what you have to do, right? Because this is a sort of like when there's an acute symptoms out there, right? That clinically, they're symptomatic patients when it comes to acute heart failure. Now, this is what you do, right? Then after that, when it comes about, let's just say, drug therapy, right? What are the drug therapy that you can do is, look, for the acute heart failures, one of the drugs, right? We call them a diuretics, right? These are very, very important diuretics, right? And most commonly we use something called loop diuretics, right? Now, what are those loop diuretics? Like, for example, if I quickly write some of the drugs, like one is called furosemide, right? Furosemide is there. Or you have a torsemide is there. Or you have a bumetanide is there, right? And also, because these three contain sulfur, there's other drugs who do not contain no sulfur into it, and this is called ethacrenic acid, all right? Ethacrenic acid. So these are loop diuretics you can use, all right? Or you can use like a thiazide, or like a thiazides are there. Thiazides? Like, for example, hydrochlorothiazide is there, or we can use a metallozone, drugs like this, right? Or chlorothalidone, those are drugs. So this is diuretics, or usually initial therapy to manage your acute decompensated heart failure, right? You gotta give it to them. Now, this is one of the drugs. This drugs is initial therapy, right? For the acute heart. Second drugs you could give is something called, look, nitrates, right? Nitrates are very, very important. Specifically, you can give something on nitroprusside, right? Or this is isosorbide dinitrate, right? You can use this drugs. So you have a 1, 2, and then on top of this, third drugs will be like something called phosphodiesterase 3 inhibitors. Now this could be good. So you have and what are these? Like, for example, milrinone, drugs like milrinone. Or you have something called inamidone. So these are what? Phosphodiesterase 3 inhibitors, right? So these three drugs, you could use it for acute decompensated heart failure. Most commonly, these are the drugs that you use, right? Now, on top of this, when you manage a chronic heart failure, right? This is where you have to use drugs like something called angiotensin receptor, okay? Neprilysin inhibitors. This is called angiotensin receptor neprilysin inhibitor. Like, for example, this is usually, you use combinations of two drugs called anestro. This is where you have something called, let's just write down here, sacubitril. Your sacubitril is there. This is drug plus valsartan. Right? So your sacubitril and valsartan. This sacubitril is a neprilysin, NEP, neprilysin inhibitor. All right? This is a drug. So this is one of the chronic therapy to maintain heart failure. Second is that you could do something called ACE inhibitor. Right? Like what? Like ACE inhibitor. Like for example, we can use like a lisinopril. Right? Or you can use all this prol drug, like you have enalapril. Drugs like this, okay? Lisinopril, enalapril, you have ramipril. Drugs like this. Or you can use ARB, which is the angiotensin receptor blocker. Like for example, valsartan is there. Or you have a sartan is there. All these sartan drugs you can use, right? And then third is, obviously, you can use loop diuretics, right? Loop diuretics also can be used even in the chronic hyper heart failure, all right? But usually, loop diuretics are used for the symptomatic patients, all right? Symptomatic patients. For drugs, you have ACE inhibitor is there, you have this, and sometimes, like there are combinations. If the ACE inhibitors or ARNI, if they don't work, right, then you could use, like for example, hydrolizin plus the nitrates, the combinations of these two drugs, all right? So you have a hydrolizin and combinations of nitrates could be used in a chronic if, let's just say, ACE inhibitors or let's say ACE inhibitors or RNE doesn't work, right? And the fifth is the very, very important, you've got to use beta blockers, right? Beta blockers. These are the drugs. Now, these drugs, beta blockers are very, very important. You can use for chronic heart failure. But remember this, beta blocker you cannot give. Please remember, please write it down. Beta blockers you cannot give in what? In acute heart failure. So, or acute decompensated heart failure. When patients are showing clinical symptoms, right, you cannot give beta blocker. It's a contraindicated in here, okay? And we'll talk about why it's contraindicated because we're just listing the drugs here. And then 6 is like, you can also give something called spironolactone, or like, I could say this, rather than writing spironolactone, I'll write down here, aldosterone or mineralocorticoid inhibitors, right? Or potassium sparing drugs, like for example, this is what we talk about, the spironolactone, or you have a eplerenone. So these are the drugs you can use for chronically, right? Like now, look what we talked about. So look, the way we do it. So when it comes about like acute, right? So sometimes people who are showing clinical symptoms, you gotta give like, diuretics, and obviously you gotta give nitrates, right? Those are the usually most two common type of drugs that you'll probably see in your clinical rotation. If the patient comes to heart failure with acute decompensated heart failure, then they will give you that, right? If we're talking about chronically managing, right? Then obviously maybe they might give a small lower dose of the diuretics, but most commonly they give RNA, which is the combinations of sacubitril and valsartan, right? And ACE inhibitors, or beta blockers. Like for example, what are the beta blockers? The 3 beta blockers that's commonly used for the chronic heart failure, right? And one is metoprolol, or this one. Second one is like a bisoprolol, and the other one is you have a carvedilol. Okay, these 3 drugs are the beta blocker that can be used for the chronic heart failure, but this is not used for the acute decompensated heart failure, right? Or you can give a mineralocorticoid receptor like spironolactone or eplerenone, right? Look, when it comes about, let's just say, acute heart failure, these ACE inhibitors or ARN can be also given here, okay? Can be given even in here too. So these guys can even come here. But when we say chronic, I'm saying that initial long management. If you're talking initial long management drugs, then that's where we're giving like ACE inhibitors or sacubitril or valsartan, right? We're talking about that. We're talking about like beta blockers. We're giving those drugs, okay, to manage from the initial to long therapy, right? Now, this is how you can divide your drugs and acutely or chronically which drugs you have to give. Now, on top of this, you have to also manage something called, okay, if you have a heart failure, then you need to have something called lifestyle modification too, right? For example, people with a heart failure, they need to be on a sodium restriction diet, right? Why sodium restriction diet? Because if you take a lot of sodium, that increases the plasma osmolarity level, right? Which causes release a lot of ADH, antidiuretic hormones, and that will result in the retentions of water, right? So there will be volume overload. So you don't want to do that. So sodium restriction is very important. Make sure that these people exercise, right? Exercise, they're losing weight, right? They're not like obese and stuff, right? So this is something that you should remember. And plus, please remember that people who have a heart failures, right? What happens is they are not supposed to take like medication like NSAID, right? Because if you take NSAID medications, like for example, ibuprofen and all, they usually, the prostaglandins play very important during vasodilations in kidney, right? So let's just, if you give you NSAID, you block them, right? You block them. So it's because of what happens is that you're activating you're gonna activate, if you they do a vasodilatation, that means decreasing the perfusion to the kidney, and that can activate the renin pathway, renin-angiotensin elastomer system, and that's going to exacerbate heart failure symptoms, right? So it's because of the NSAIDs are not given. Make sure you remember this, okay? So NSAIDs are not given in that settings. Now, these are the medications of the heart failure, acute and chronic. Make sure you separate them out, right? Now let's talk about what are the importance of giving these drugs, right? And this is where we have to go and talk about the pathophysiology of it, okay? Now, what about the heart problems is there, right? We have something called what? There's a decrease in cardiac output. So initially when there's a decrease in cardiac output is there, what happens? Look, that results into activations of one of the pathways, what? Activations of sympathetic nervous systems, right? Not going to go super detail. But remember, and the sympathetic nervous system, what happens? They release epinephrine, norepinephrine in where? On a beta 1, right? Beta 1 receptors, and also in the what? Alpha 1, correct? Plus, these guys also work on the what? Also work on the venous side, right? So I'll write on the venous side. This is what happens. Now, where does the beta 1 receptors are located? It are located on the SA nodal cells, AV nodal cells, right? Beta 1 receptors are located where? SA nodal cells. And SA nodal cells, if they work on there, right? What happens? Now, for down here, let me actually make a 1 cell right here, right? Let's just say it could be right here. We can make, let's just say, for example, this is 1 cell. And if they work, release norepinephrine or epinephrine, then what happens? That increases your heart rate, correct? That's what happens. And then if they work on alpha 1 receptor, which are located where? In the blood vessels, right? In the afferent arterioles or in your artery side, right? And that can release norepinephrine, epinephrine, and that can cause constrictions of them. And that constriction results into what? Increase in what? Total peripheral resistance. That's what they do. And blood pressure is equal to what? Systolic times diastolic. Or I can write down blood pressure is equal to cardiac output times TPR. If you increase your TPR, right, you increase your blood pressure or you increase your mean arterial pressure. That's how we do, right? And by working on the venous side, right, they have alpha 1 receptor located on the venous side. But what happens? They increase the venous return, right? If you increase the venous return, you increase the end-diastolic volume. If you increase the end-diastolic volume, you increase the preload, right? And if you increase the preload, what happens? You increase the cardiac output, right? This is what happens. And if you increase the cardiac output, you increase the systolic pressure, right? This is what happens, right? Now, on top of that, this guy's also beta 1 receptors are located where? Obviously on the AV nodal cells. So that results into what? That results into increase in conductions, right? Increase in conductions. So I'll just write increase in conduction right here. Plus, they also work in what? In the ventricular myocytes. And the word, look, now this is ventricular myocytes, right? And when you release norepinephrine or epi, right? What happens? Obviously, this is coupled with the G protein, right? The 7-pass memory receptor. And I'll just write on your adenyl cyclase enzyme, right? There's a GTP is there. They go and stimulate the adenyl cyclase, which converts what? ATP into cyclic AMP, right? And cyclic AMP leads into activations of protein kinase A, right? And this phosphorates the L-type of calcium channels and all, depends on what myocytes you're talking about. If you're talking about ventricular myocytes, L type of calcium channel, a lot of calcium will come, right? And what happens? A lot of this increase the rate of cross-cycle business forms and ultimate increase in what? Contractibility, right? This is what it does. Now, increase the height rate, increase in contractility because it is working the ventricle massage, right? Now, beta 1 receptor also located where? In the renin, right? Look, in efferent arterioles, right? They have something called, like macula densa right here, and you have some cells like which are called LASIK cells, right? And you have something called, there's cells like glomerular cells, granular cells, and altogether what happens? They make juxtaglomerular cells or juxtaglomerular patterns. Beta 1 receptors are located there, and what happens? By activations of sympathetic nervous systems, right? They will cause a constrictions on here and release what? Renin. That's what they do, right? So one way is that the renin is also going to get stimulated, right? Now, on top of this, when there's a decrease in cardiac output, this tissue is becoming what? Less perfused, right? When they become less perfused, the glomerular filtration rate decreases. That means a less amount of sodiums and water, sodium plus chloride is getting into what? Into this, macula densa cells, right? And they sense it and they release renin. That's what they do, right? So different mechanism is leading to activations of renin pathway. So I'll make another diagram right here. What happens is that there's activations of renin, right? And what renin does is that, let's write it down here. Renin goes, right, and converts angiotensinogen into what? Angiotensinogen number 1. That's what it does, right? That's what it does. And then angiotensinogen, it goes to the lungs, and there are enzyme, they see something called ACE enzyme, which is the angiotensinogen converting enzyme, and converts angiotensinogen 1 into angiotensinogen number 2. That's what it does, right? And angiotensinogen 2 has a receptor located in where? In the afferent arterioles right here. Also the efferent arterioles, that's what they do, right? And they can come. And then what happens? They can constrict the efferent arteriole, increase the total peripheral resistance. They can also constrict the efferent arterioles. That's what they do, right? They can also go to this proximal tubular cells and reabsorb sodium and water. That's what they do. They go to what? Your brain. And then what? They stimulate the thrust center, so you increase the water intake, right? They also go to the brain, and what happens? Stimulate the release of antidiuretic hormones. So angiotensinogen has a lot of functions, right? It has this one I just mentioned. On top of this, angiotensinogen 2 also causes the release of what? ADH and also the aldosterone, right? Very, very important. Now, this ADH comes here in the collecting tubules, and what happens is that increase it puts aquaporin channel and reabsorbs sodium and water. Aldosterone, it works on the principal cells in the collecting tubules, and puts like a lot of this sodium channels, right, enad channels, and it throws out potassium, so reabsorbs a lot of sodium and water. So basically what it's doing is it is adding what? It increases sodium plus water retention is happening, so you're increasing the what? Volume, right? That is what you're doing. Same with ADH does. Look at this. So this is what is happening, right? In acute this is sort of like acute compensatory mechanism is happening, right? That's what is happening now. So now you see why these drugs are used in the acute heart failure, because we are basically blocking this. And you remember the compensatory mechanism is the one that exacerbates lead into the decompensations, all right? So please remember. Now think about it. Now if you want to manage, right? Manage your heart failure. How do we manage the heart failure is this. What are our targets? Let's go about our targets. We're going to go about, look, if you talk about RAS pathway, right? What RAS is doing is this. RAS is ultimately adding more sodium and water, right? So it is basically increasing the volume over state, right? That's what they're doing by the RAS pathway. That's what they're doing, right? Now, volume over state, that is not a good thing, right? So that means that they're increasing what? Increasing a preload. That's what they're doing, right? So they're what? They're increasing a preload. So we have to, if you want to manage, let's just say, if you want to manage your heart failure patients, then what happens? The first thing you have to do is you have to decrease the preload, right? So that means that our drug should be what? We have to give a drug that actually decreases our end diastolic volume or decreases our preload, right? Because your RAS, well, write down here. Your RAS is what? Your RAS system is adding what? Increasing what? Preload. That's what they're doing. right? Plus also sympathetic nervous system also by constricting, doing a vasoconstriction, it is increasing the venous return and also increasing the preload, right? So RAS plus the sympathetic nervous system, both are what? Both are leading into increase in preload. That's what these guys are doing, right? So we have to somehow decrease the preload because adding a lot more blood volume, that is going to exacerbate like the edematous conditions, right? So that is why we have to have drugs that decreases the preload. Right? That one, that's the number one we have to look at it, right? Now, second point we have to look at here is this. We're going to just follow the pathway. We're going to write down 2 here, right? Let's look at this. What is this? What do you think? We increase the total peripheral resistance too, right? By constricting at the alpha 1, correct? So somehow we have to decrease this total peripheral resistance too, right? Or decrease. So we have to give it drugs that can dilate arteries. And what? So that's going to dilate arteries. So we have to have drugs that decreases what? Afterload, right? This is also management of our heart failure. Now third is, look, now what do we do? You know, look at this, contractibility. We want to have an increase in contractibility, right? So we have to maintain the contractibility of the ventricular myocytes, right? So we have to give it drugs that is going to actually increase what? Contractibility. That's all also we need to have. So we have a drugs that needs to increase in what? A contractibility. Contractibility. This needs to be there too, right? And then fourth is this, that look, this is very, very important. That is that, look, you know, this sympathetic nervous system, what are they releasing? When there's an overactivation sympathetic nervous system, right, beta 1, adrenergic, right, they're releasing what? Catecholamines. That's what they're releasing, right? They're releasing catecholamines, and on top of they're releasing what? Like catecholamines like epinephrine, norepinephrine, dopamine they're releasing, right? Plus, because of the RAS pathway, right, there's a lot of aldosterone is there, and you've got to remember this, okay? So aldosterone, you've got to remember, aldosterone, right, plus the epi or norepinephrine or dopamine, right? All this, you know what they do? They overstimulate the cardiac myocytes, right? And when they overstimulate the cardiac myocytes, the cardiomyocytes started changing, right? So there's a whole cardiac myocytes remodeling happens, okay? So this aldosterone and then also the adrenergic agonist, right? This beta agonist, right? Like epinephrine or dopamine, they increases what? Cardiac myocytes, let's just say myocytes remodeling, right? And this remodeling lead into some of the myocytes becomes like necrosis, all right? Necrosis, you start seeing fatty changes. Plus some of them will go to something called apoptosis. That's what really happens. And there will be a fibrosis you started seeing, right? So there is a whole ventricle or cardiomyocyte remodeling happens, and that's where you see a necrosis, apoptosis, and fibrosis happens. And this fibrosis or necrosis as well, they don't do contractions, right? So if you don't do this, because this happens, cardiomyocyte remodeling happens, right? If there's a increase in cardiac remodeling, which is leading to even hypertrophy and all, this increases the mortality rate, okay? Because if the myocytes become very, very fibrosed or it become dead, it started dying, then what happens? Your heart is not going to pump, right? So this increases what? This increases your mortality, right? Increase mortality plus increases your hospitalization. So increase mortality. So that means that we need to have some sort of drugs that can what? That can decrease the mortality or that increases the survival, right? So we have to block aldosterone or this epinephrine, norepinephrine, dopamine or beta. We have to block this beta agonist drugs, right? Like we also sometimes we call this a sympathomimetic drugs. So we have to block the sympathomimetic drugs, right? So that is why in the fourth point, this is where we were talking about the increase what? Drugs that increases the survival, okay? Survival or decrease the mortality. And how does this happen? So somehow we need to give it drugs, right? That decreases the cardiac myocytes remodeling, right? And for that we need to block. Because which one's actually causing cardiac remodeling or increasing the cardiac remodeling is aldosterone and your sympathomimetic drugs. So we need to give a drug that decreases the aldosterone level, and we need to give a drugs that actually decreases the what? Epinephrine or dopamine or yeah, we need to decrease the sympathomimetic function, right? So that way there's a less stimulation of cardiac myocytes, so less remodeling happens, and then that leading to what? Increase in survival of the person, and also decreases the hospitalizations of the person, right? So we have to give out drugs that lowers the aldosterone, that lowers the sympathomimetic drugs, right? So this is how we have to manage it.